Good afternoon, everybody. Welcome to today's webinar on maternal depression and young adult mental health, policy agenda for systems that support mental health. Next slide. Today, we are joined by Nia Westbay, Senior Policy Analyst on the Youth Team at the Center for Law and Social Policy, also known as CLASP, and myself, Ruth Cosi, Policy Analyst on the Child Care and Early Education Team here at CLASP. Today's guest speakers are Joan Yengo, Chief Program Officer at the Mary Center for Maternal and Child Care. Ms. Yengo oversees the social services, behavioral health, home visitation, teen, early childhood, senior wellness, public benefits, and WIC programs. Part of her work with Mary Center is to support communities served through committee facilitation, community engagement, and advocacy efforts. We are also joined by Bree Maselli, Director of Technical Assistance and Evaluation at Youth Move National. Ms. Maselli serves as a lead for children's mental health initiatives, coordinates technical assistance providers, organizations, and communities seeking to become youth-guided and trauma-informed in order to better serve the needs of family and youth who are experiencing challenges with behavior and emotional health issues. Next slide.
As we close out Mental Health Awareness Month, today's webinar will provide an overview of CLASP Maternal Depression and Young Adult Mental Health Policy Agenda for Systems that Support Mental Health and Wellness report that came out a few months ago. And then we'll hear from our two partners, from Mary Center in Washington, D.C. about the Maternal Mental Health Program, and Youth Move National about their work with youth and young adults supporting their mental health. Then we'll close with questions from you, the audience. Next slide. The Center for Law and Social Policy, or CLASP, is a nonprofit anti-poverty advocacy organization in Washington, D.C. that's been around for nearly 50 years. We work at the federal, state, and local levels to advocate for policy and systems changes that support low-income people. The work that we'll be sharing from CLASP today was the kickoff of a project with a goal of bringing together two learning communities comprised of small groups of states who want to work together to make policy and systems changes to better support the mental health needs of youth and young adults and moms who are experiencing depression. If you have more questions about CLASP or about this project, we'd be happy to answer them during the question and answer period. Next slide.
In February of this year, CLASP published the Maternal Depression and Young Adult Mental Health Policy Agenda for Systems that Support Mental Health report. This is a cross-team report stemming from CLASP Child Care and Early Education and youth teams in order to better provide context and an understanding of systems that support the mental health and wellness among low-income mothers experiencing depression and young adults living in poverty. Next slide. In order to better understand the prevalence of maternal depression and young adult mental health, we must highlight the scope of this issue. Firstly, a combined 3 million Americans living in poverty are either a mother who has experienced depression or a young adult who has experienced serious psychological distress in the past year. Untreated mental health needs have widespread implications and consequences to the well-being of mothers, young adults, and their families. This is why it is critical that we work to improve policy to better meet the mental health needs of young adults living in poverty and low-income mothers experiencing depression. These positive policy-driven solutions can help promote a healthy development and long-term success among these populations. Next slide.
As part of our efforts to scope this challenge, we analyzed from data from the National Survey of Drug Use and Health, an annual data collection on the mental health needs and substance use of Americans. One of the key findings from this work was that young adults who experience psychological distress are more likely to be living in poverty. Serious psychological distress is defined as subclinical depression, anxiety, or emotional distress experienced in the worst month of the last year. If you look at the top or the dark red bar, you can see the poverty rate for young adults who have experienced serious psychological distress in the last year. And the bottom bar presents the overall young adult poverty rate in each of these groups. In every demographic group, experiences of serious psychological distress are associated with higher poverty rates. In addition, there's a significant gender gap, with young women more likely to report serious psychological distress in the last year than young men. Next slide. There are also economic consequences of depression for moms. If you look at the first bar, you can see that overall, moms are more likely to be poor than the general population. The overall poverty rate in the U.S. is around 13%. For moms, it's closer to 15%. But what was truly shocking in this data is that 1 in 4 white mothers, 1 in 3 Hispanic mothers, and 1 in 2 Black mothers who have experienced major depression in the last year are living in poverty. And these consequences are enduring, with the rates essentially unchanged when you look at moms who have ever experienced major depression in their life. Next slide.
A key part of this report in overall mental health is the shared context of structural barriers and inequities. Disparities in social determinants of health further perpetuate mental health challenges among young adults living in poverty and low-income mothers. Unaddressed mental health challenges among young adults undercut their economic stability. In addition, economic challenges tend to be very prevalent for mothers of young children. 1 in 6 young adults between the ages of 18 to 24 live in poverty, and nearly half of related children under 6 with a single mother female householder live in poverty. Both young adults and mothers living in poverty experience disparities in health insurance rates and health outcomes. Nearly a quarter of both young adults and mothers living in poverty do not have health insurance. In addition, education is also connected to mental health. Low-income young adults are more likely to attend under-resourced schools and experience disproportionate rates of youth disconnection. Among single parents living in poverty who reported 2 or more depressive symptoms, only 11% of single parents had completed some college versus 50% of all parents living in poverty. Next slide. Low-income mothers and young adults living in poverty also experience disproportionate exposure to trauma and toxic stress. Toxic stress is defined as when a person experiences strong, frequent, and prolonged adversity. According to the 2015 National Survey on Drug Use and Health, 60% of mothers living in poverty report serious psychological distress. This includes 26% of white mothers, 15% of Black mothers, and 9% of Hispanic mothers. Among mothers between 100 and 200% of poverty, 18% of white mothers, 8% of Black mothers, and 7% of Hispanic mothers experience serious psychological distress. Next slide.
The Affordable Care Act supported significant gains in coverage for both young adults and for moms, especially in Medicaid expansion states. As we already mentioned, the poverty rate overall has come down to the uninsured rate overall has come down to 16% for Americans living in poverty since the implementation of the ACA. However, there are still gaps, as 22% of young adults and 23% of mothers living in poverty remain uninsured. And not only are there gaps in coverage, there are gaps in knowledge about whether or not insurance covers mental health services, with many youth and young adults in particular reporting that they don't know that they can use their insurance for mental health services. Putting insurance aside, there are a number of other key access issues faced by these populations. One is the setting where services are provided. Many moms indicate that they prefer to receive services through home visiting or at the pediatrician's office, with young adults talking about a preference for services in school or community-based organizations that don't explicitly focus on mental health. There are also issues of quality, with low-income people, and particularly people of color, more likely to only be able to access low-quality service, and talk from young adults in particular about the use of law enforcement as first responders to mental health crises. This typically exacerbates the situation and increases their risk for contact with the criminal or juvenile justice system. And then also really important is our concerns around the cultural relevance of available service. Young adults have talked about the importance of shared background and peer-to-peer approaches, and there are real questions about whether or not the typical assessment and screening tools are effective for all of the relevant populations. Next slide. Despite the formidable challenges that we've outlined, change is possible. And one of the examples of that are human services partnerships at the local level and local innovations. Two examples that we'll talk about briefly are the Moms Partnership in New Haven, Connecticut, which includes mothers from the community serving as community mental health ambassadors who deliver screening, brief intervention, referral, and clinical treatment in partnership with clinicians. There are efforts underway to make these services Medicaid reimbursable, and the services occur both in traditional clinical settings as well as community-based settings such as grocery stores or the mom's home. Also in Los Angeles, we learned about Community Partners in Care, which is an effort to integrate community-based human services and trusted local institutions with researchers and more traditional health and mental health providers. So this effort incorporated the Department of Parks and Recreation, beauty and barber shops, faith-based institutions, libraries, a host of institutions that are not traditionally considered mental health providers, and increased their capacity to effectively service these populations with real measurable impact for people who are experiencing depression. They saw improvements in their reported quality of life, in their risk for homelessness, in hospitalizations, real critical impacts focused on the Black and Latino community in Los Angeles. These local systems building initiatives should, while not replicable everywhere, definitely provide some insight into what's possible when a community comes together to really build a comprehensive system around these populations. Next slide.
As you can see listed below, there are an array of evidence-based mental health interventions that have been proven effective for young adults living in poverty and low-income mothers. In the maternal depression space, effective interventions range from pharmacotherapies to alternative medication to cognitive behavior therapies with modifications such as support for childcare. These interventions don't solely help the mother, but the child as well. Ultimately, effectively treating parents is also prevention for children. In the youth and young adult mental health space, effective interventions include school-based interventions, youth peer specialist programs, and trauma-informed practices. Next slide. The ACA's requirement to insurers, including Medicaid, to provide mental health services as part of their essential health benefits packages includes quality indicators and free preventive coverage for depression. In addition, it encourages integrated, team-based care in ways that could support families living in poverty. These changes to healthcare are one step in the right direction in eliminating historical barriers that have hindered depression treatment for poor mothers and mental health support for young adults. ACA's Medicaid expansion has helped increase health insurance coverage and access to health and mental health services. Specifically in expansion states, the uninsured rate for low-income parents is 11%, and in non-expansion states, it is almost 34%. In the first year of full implementation of the ACA, the uninsured rate for young adults living in poverty fell from 35 to 24%. Next slide.
This information led us to develop a 7-point action agenda for state-level policy. First, prioritize Medicaid expansion and reject changes to Medicaid programs that create additional barriers to care. Work requirements, lifetime limits, a host of efforts that are coming out of states that are intended to limit access to care actually risk undoing the gains that we made under the ACA, and there was still work to do, particularly for the populations that we're talking about. States should focus their effort on continued efforts to make sure that everyone has access to insurance coverage. Second, commit to full implementation of the mental health parity and prevention provisions of the ACA. While there has been some progress, particularly in physical health, in terms of the continuum of services that includes prevention and promotion of wellness, the parity piece of mental health has not really translated that into making sure that there's support for the full continuum of services, from promotion of wellness to prevention to intervention to treatment. States have an opportunity to really take a look at parity with an eye towards making sure that the full continuum of services is appropriately supported and funded. Third, build partnerships across agencies, levels of government, and types of service providers that support systemic solutions and capitalize on the strengths and resources of different partners. Youth development, youth workforce development, child welfare, juvenile justice, child care, Head Start, all of these agencies have something to contribute when coupled with more traditional health agencies and health providers to effectively really build a system of supports and a network around these populations. Fourth, improve integration of providers at multiple levels of credentialing and with multiple backgrounds into care systems. Young people, moms, people of color specifically have talked about the role of non-traditional providers, doulas, traditional healers, other types of providers in meeting their needs. So sometimes credentialing and licensing requirements can interfere with the ability to get reimbursement for these services. And states should really take a look at their policies to make sure that these types of non-traditional providers in traditional and non-traditional settings have a role to play. Fifth, identify effective reimbursement strategies, reduce reimbursement obstacles, and support advocates and policymakers to understand and take full advantage of existing reimbursement levers. States have a lot of opportunity to make choices in terms of what services are reimbursed, at what levels, and using which billing codes and under which mechanisms. If states want to take an eye to their reimbursement policies, thinking really intensively about how to best support these populations, there are chances to really make some differences and make some policy changes that can have a really meaningful impact for these young adults and for moms. 6, use flexibility available under current Medicaid statute to fine-tune care and benefits. Historically, waivers were intended to expand coverage and expand the available services. States really should be looking at waivers through this traditional eye, thinking about things like the 1915 I waivers and the home and community-based services waivers that let states think about creative services, about wraparound, around additional supports that are needed by these populations, and can really provide an opportunity to add to the range of services and to the number of folks who are covered. And finally, anchor these efforts in the understanding that an equitable process for identifying and implementing solutions is indispensable to achieving equitable outcomes. There really are opportunities to decrease the disparities both in access and outcomes for these populations, but that requires authentic partnership, engagement, leadership, and voice from those who are most impacted, in this case, youth and young adults and mothers themselves. Next slide. So we only had time to touch briefly on some of the key points in the report today, but if when the webinar is over, you want to read the whole thing, you can find it here, and you can also check out some of CLASP's other mental health resources. And now it's my pleasure to introduce Joan Yango from Mary Center in Washington, D.C. to share with us about how they are working on maternal mental health in Washington, D.C. Joan?
Hi, good afternoon, everyone. So the next slide. Hi, so Mary Center, we were founded in 1988 to respond to the immigration that was coming from Central and South America during war-torn times, civil unrest. And there were many women that were crossing the border, seeking care, often raped, coming pregnant, who needed help. And so Mary Center was founded to address the perinatal needs of those women. Over the years, we have grown our program to now be a federally qualified health center. We served over 50,000 people this past year, and we have 5 sites in Washington, D.C. and Maryland, and our budget has gone from $250,000 to $59 million. Next slide. With the Mary Center model, we work in a social change model. So there's a recognition that you cannot address health alone and health care alone to meet the many needs that can be impacting a human being in a family. So we've worked to have an array of other services and supports to help respond to those needs. So we have the whole spectrum of healthcare services, but we also have added over the years case management, senior wellness, early intervention, home visiting, public benefits, adolescent services with our education, after school programming. We partner with BRIA, a family literacy program. So as a participant comes for care at Mary Center, we work to identify how can we best support them and link them with those resources either internal to Mary Center or external that can best meet their needs. One of our growing programs is the behavioral health program. And within our behavioral health program, we have our school-based mental health program, parent-child interactive therapy, we have telebehavioral health, and our maternal mental health program. Next slide. And our maternal mental health program is actually managed by Morgan Gross, who unfortunately could not do this today, but she is our manager who really is the one that spearheads and runs this program. Next slide. So how the maternal mental health program came to be. Mary Center, as we develop programs within our organization, are responding to what the community is telling us is needed, and we're identifying and seeing as needs for the community. So back in 2014, one of our staff that came on board, Lynn McIntyre, who was a licensed independent social worker, and she herself had experienced perinatal mood and anxiety disorder. And she had this experience, and when she had it, it raised her awareness of the lack of resources and supports for women and the lack of understanding of perinatal mood and anxiety disorders. So she reached out to us at Mary Center, and we discussed, okay, how can we really begin to address maternal mental health, and what is it that we need to address the program? And the first thing we needed was to identify funding. And one of the positive things is the Pullinger Foundation has a vision to really look at how to invest in systems change and approaches, and they partnered with us to launch the Maternal Mental Health Program. And during this period of time, we developed a needs assessment to really dig deep and see what is necessary for this area. Throughout that needs assessment, we identified a champion training model, and we've trained champions to train others to understand perinatal mood and anxiety disorders. And through this time now, we're at a point where we're identifying how we can spread this more effectively throughout our systems in the DC metro area, with mini grants to fund new programs and new innovations, and we've launched our maternal mental health newsletter. Next slide. So a key piece of our perinatal mental health care needs assessment, that's where we started. We wanted to get a good idea of what are the attitudes, the beliefs, the practices within the primary care, behavioral health, and other settings that demonstrate how we're being responsive or non-responsive to the issues of maternal mental health. Through this process, we partnered with Children's National Medical Center and their collaborative on mental health in pediatric primary care, specifically Sarah Barkley Hoffman, to really get their listservs, our listservs. Let's see what we want to ask and see what are the needs in the city. Next slide. And so we did an assessment, three separate assessments. Pediatric primary care providers, perinatal health care and related providers, including lactation consultants and home visitors, and mental health professionals. We used a 5-point Likert scale for strongly agree to strongly disagree, looked at ranking barriers to identification of treatment of PMADs, level of experience treating perinatal women, and amount of training, electronically distributed these via professional email listservs, and then we had follow-up interviews as needed. Next slide. And what we saw, we did receive surveys by the professionals. We had follow-up interviews. There was a significant diversity in healthcare providers. We got MDs, nurse practitioners, registered nurses, midwives, dietitians, lactation consultants, social workers, home visitors. A whole range of folks did respond to our survey. And then if you go to the themes, the results, next slide. So what we were seeing, which was interesting, a responsibility of perception gap. Providers didn't feel that perinatal families view their primary care provider as a natural source of information and assistance. There was a feeling that we need to train providers on how to talk about perinatal mood and anxiety disorders and raise public awareness efforts aimed at normalizing the experience. We also saw with experience and training that training was a key thing that people wanted. There was a thirst for knowledge, for understanding, and more information. And with screening, while we did see some providers were screening for behavioral health or depression concerns, there were specific problems with the screening process. There was not consistency, there was a lack of protocol or misunderstanding, not following up. And then there was a concern at the time, lack of reimbursement for this service. There was a lack of confidence by folks that were screening in terms of their effectiveness and their ability. And awareness, there was also a lack of awareness of what resources were out there that existed when there was a positive screen. And pediatric providers a lot says sometimes they do screen, but only when the mom appeared to be in distress, which also indicated that more training was needed. The availability of resources, a lot of providers reported having no knowledge of access to resources and very concerned about how they would link. Only a third of the mental health survey respondents participated with any insurance plans. Training efforts on mental health providers who participate with public insurance and who are paneled with plans also needed to have they needed more information. And one of the biggest response gaps occurred between mental health professionals who report significantly higher levels of consultation with healthcare providers than healthcare providers reported that they received. So there was this feeling that the behavioral health providers said they were there, they were available, they were providing support to healthcare providers when there was a concern, but they were not getting the support. But the behavioral health providers felt like they were giving it a lot, and the health providers said they weren't getting enough. And then there were obstacles. So many respondents referred to financial barriers and referrals for treatment, and it's just the long-term cost of ignoring that problem up front. So in sum, that we were just seeing that we need more screening and resources for referrals, and support those that are screening, understanding what those resources were, better training of understanding what perinatal mood and anxiety disorders are. And we were seeing too obstacles for the moms and the families. The time and other life demands were getting in the way of accessing resources. There still maintains a stigma and cultural barriers. There are still financial issues. There's lack of availability of experienced mental health care providers. And there are logistical barriers in terms of lack of transportation and childcare. Next slide. So with that, based upon that needs assessment and those results, that's where we developed our maternal mental health program. And it included training, advocacy, and education, participant navigation, and clinical and other direct services, phone outreach, support groups, therapy, psychiatry, and linkage with those other related programs that can best meet their needs. So a key piece is the Champion Project, the trainer projects. It was a 9-month training project to create a group of perinatal mental health trainers in the district that could go and train others and raise awareness on those areas that we saw were needed. Understanding what perinatal mood and anxiety disorders are, understanding how to screen, what to do if you get a positive screen, how to talk to participants, and then how to refer and appropriately refer. Next method. Next slide. So at the end of the training, we really work to support the understanding of the different perinatal mood and anxiety disorders that can be present, know the incidence and prevalence of PMADs and their immediate and long-term effects on the mother and children, understand major risks, learn how and why and when to screen, and how to identify a validated instrument, know what's available in terms of resources and supports, and know how to talk in a culturally aware and trauma-sensitive manner to a new mom who is suffering, and what the possible treatments are, and know where prescribers can access up-to-date information about medication and pregnancy. And then based upon another piece of it, so we trained all the trainers, the 22 champions were able to train 1,600 people. And another aspect of it, again, was once you're trained and you're starting to screen and you're identifying participants that could benefit from services, what do you do and how do you do the process? So internally in Mary Center, our pediatricians, OB, midwives, all programs, home visiting, WIC, even self-referrals can refer for support through electronic messaging system within our electronic health record, as well as a warm handoff. External, as we were supporting across the city, again, identifying these are the folks that can screen, these are the resources that you can access, and these are our partners, and you can refer through phone and email. Screening is and the other piece that we really work to drive home is screening is key. We did hear reports that a lot of providers would only screen if someone looked or appeared to not be doing well. So we supported them in understanding you have to screen, learn how to have the conversation to be able to provide the appropriate referral. Next slide. And then just what we are seeing clinically with perinatal mood and anxiety disorders, pregnancy and postpartum prevalence 10 to 20%, up to 1/3 of the women in poverty and our immigrant women. We see obsessive compulsive disorder, generalized anxiety disorder, depression, and PTSD. Our population has a lot of trauma, especially seeing perinatal mood and anxiety disorders when there was rape, sexual abuse in the past, Also, if they were during delivery, if there was a feeling of powerlessness, a lack of support, poor communication and reassurance, a lack of respect during delivery, or if the baby was in NICU, we're seeing perinatal mood and anxiety disorders. Next slide. So there are obstacles with referral and treatment and screening. There can be lack of comfort with answering screener truthfully. There's still a lack of trust in systems, and there's still a fear if I reveal anything about my mood or say anything, my child may be taken away. They may label me as a bad mother, that denial and that shame feeling. And there can also be interpersonal violence or domestic violence that also impacts in the woman's ability to really understand what's happening or know that they can get help or that there is help. And then the participant's perception that it isn't a big deal. They have this past history with a lot of risk. This is just, life is just very hard. This really isn't just how life is. I can't get help. Next slide. So additional barriers, when there is a history of trauma, multiple stressors impacting recognition of the concern and support available, the economic, transportation, employment, childcare, all those pieces with limited social support can impact one's ability to access care. And lack of choice, a provider who looks like them and speaks their language, accepts their insurance, is hard to find. And additionally, you need a provider that can meet participants where they are, does not have, their bias or make assumptions based upon who they are, what their age is, what their race is, or their country of origin. So that's our program and how we trained. And we also, with challenges, continue to find funding challenges for creative ways to explore different reimbursement strategies, how providers can be reimbursed, and how we can support care and navigation. There are still no-show rates in terms of participants continuing on with care and support and therapy. There are very limited services within the metropolitan DC area, Washington, D.C. area, within one of our quadrants in the city, within the southeast in the city, the availability of providers to really meet the demand that's out there. And then we still need additional clinical support, folks trained that can really respond appropriately, and advocacy. And a big challenge that we are seeing too is linkage to care and getting to that first appointment. We are seeing, even when we do a warm handoff and introduce and engage someone, that they still might not come back for their second appointment. So we're really trying to work to identify what kind of care coordination or support to help keep them coming. We're also seeing, just in terms of these challenges, boyfriends that don't want the participant to come for therapy, stigma that still continues. Another family where a woman was severely depressed and the family would not let her take her medication. So the family is a very important strength for her care for baby and mom, but very resistant to medication due to the stigma. So with successes, we did see an increase of awareness in maternal mental health at Mary Center and citywide. We definitely are seeing screening at multiple points of service entry, centering pregnancy programs, pediatric appointments, prenatal enrollment, home visiting programs across the city, WIC programs, and centering parenting in addition to centering pregnancy. Brief intervention protocols of education and follow-up and referrals as indicated by the stage of change of participant, and that's primarily with home visiting. One of the key pieces with home visiting, when you have a participant that is not during her prenatal and postpartum period that is also enrolled in the home visiting program, the home visiting family support worker is key in terms of helping to just be that social support, help with the education, help with information, and as the mother, when she starts identifying to recognize that she can get help for herself, the home visitor is still there to help make that linkage. So that was a key piece that really supported the program. More and more and new perinatal mental health initiatives are going on across the city. And with participants, you see improved short-term and long-term health outcomes for the participants. And it's really important to recognize here the importance of creating those systems of care. We had a mother who had said to us, if it wasn't for you and the doctor, I'm not sure I'd be alive. Things were not good when I first met you. I'm pretty sure you saved my life. And what was important is this participant was linked in with a system of care that allowed early detection of the perinatal mental health difficulty and helped her to get connected to the care needed. Because she was screened during her pregnancy and because the midwife knew what to do in response and how to link her to care, she was able to access care. She had lived through her deepest depression and birthed a healthy little girl who will now be able to benefit from the love and care of this mom who is in a much happier place. Thank you.
Thank you, Joan. Now we will pass it on to Bree Maselli, who's going to discuss mental health of young adults from Youth Move National.
Hello. So thank you for having Youth Move join the webinar today. We're a little bit of a different organization than what was just previously presented. We are a national youth-driven advocacy organization, and MOVE stands for Motivating Others Through Voices of Experience. In 2003, System of Care grantee communities that were funded out of SAMHSA really had a strong value of family-driven within their programming. And roughly about 2003, young adults stepped forward and said, well, what about our voice? And so the national language within that grantee program shifted from family-driven to youth-guided. And when youth-guided came as a very clear value of system of care, there was a lot of support needed to really understand what does that mean, how do we engage young people, how do we outreach to young people and utilize their voice within the work that each local level grantee was doing. And so that really started the youth movement and the development of Youth Move National. At that time, we were only an advisory board that was advising at the national level, as well as supporting local youth coordinators who had lived experience at the local grantee level. Next slide, please. So Youth Move's mission is really to unite the voices and the causes of youth while raising awareness around youth issues. We advocate for youth rights and their voice at the same time as empowering young people to understand their circumstances and how they're able to heal, overcome, and be resilient within their situation and join at the table as equal partners in creating change. Next slide. So our vision is that systems that serve young people see them as being prepared for life through genuine opportunities and authentic involvement at all systems level. So whether they are a recipient of service, whether they are advising the system and or working in the system, and to help redevelop the system so that the next generation enters into a more warm, welcoming, and supportive system. And so really building off of the power of their voice and creating an opportunity to foster change and build stronger and healthier communities for the next generation of young people. Next slide. So most of our young people really wanted to have an opportunity to be connected nationally. In each of these grantee programs in which we kind of grew out of, they really wanted an opportunity to be connected with other like-minded young people. Oftentimes we see youth, no matter what system they're involved in, there's stigma that is associated with that, especially those that have mental health challenges. In schools, we often see that after-school programming, those that get involved in such programming tend to be young people that are looking to put that on their college application. Not always the young people that are living in poverty, that are struggling at home and are not quite sure of the uncertainties of their life. Are they able to truly commit and or feel a part of? And so Youth Move really looked at how do we create space, how do we convene and hold space for young people that are often not able to participate in such ways in their community because they're overlooked or they're stigma associated, and how are we able to unite those voices so that they're not treated as numbers, problems, or caseloads, but as individuals and humans as well as partners in creating the change. Next slide, please. So research has shown that patients, consumers, families, those who actively engage in their healthcare teams have better outcomes and often choose less expensive options when participating in shared decision making. They express greater satisfaction with their health care experience. And so for us at Youth Move National, that is pivotal to the work that we do because all of our young adults that are involved in our work all have a mental health diagnosis or systems involvement. The majority of them have experienced trauma. Some of them are not with their families because they're in child welfare. And so when we realize that young people disengage from services or are not meeting their goals, it's because they oftentimes weren't involved in the creation of those health plans to really think about what do they envision for their life. So voice and choice is really critical. I know in the family movement, we often hear nothing about us without us. And this is the same for the youth and young adults. Engagement looks different when engaging youth and young adults. And our systems, the way they are designed, does not make that easy for us. There's often not a lot of times to build rapport and relationship in the way that our funding mechanisms are requiring us to have these 15-minute increments with children and families or these particular ways. And young people are not trusting. So for them to open up, for them to access services, that takes a little bit longer. And we need to shape our systems to create the space for their voice and choice to participate and engage in a way that's developmentally appropriate for them. Next. So why voice and choice? We know that there's been several documents over the years that have allowed us as Youth Move National to shift from a national advisory kind of capacity to several federally funded initiatives to be our own independent nonprofit organization. We know that there is a requirement in the Achieving the Promise to transform mental health care in America. We continue to be on this journey, and the voices of our young people, both nationally and locally, have been a key factor in trying to shift what mental health care looks like in America. Next. So there's a lot of value added. The value added of Youth Voice is that it changes our institutional culture and our practice. So what we are comfortable with doing in our systems, Youth Voice kind of shifts that. It forces us to think differently, act differently, and create a system that's more responsive. Young adults can contribute to the designing and implementation of new policies that better serve them, meaning that they are more engaged and they are the retention within the services is more appropriate. It builds awareness and understanding of the mental health issues coming directly from young people in their communities. It builds the individual's self-efficacy. It connects young people who are often disconnected to a sense of community and other like-minded peers. And obviously, it improves individual and organizational outcomes when organizations are partnering with one of our chapters and really creating meaningful change. Next slide. So what Youth Move became after being an advisory group for such a long time, about 4.5 years ago, we became an independent nonprofit advocacy organization, and our young people really wanted an opportunity to take what we were doing nationally, where we were really saying that youth are equal partners in this. What young people have to tell us can really shape the change in the system and improve quality. And we created a chapter membership model. So currently, Youth Move National utilizes a capacity building model that supports the individual utilizing services, the community in which they live, and the services and or supports that support them in their mental health journey. Our model consists of programming that is young adult driven and data informed. It builds upon peer connections. It promotes learning and growth. It develops partnerships and collaboration with traditional service partners as well as non-traditional partners. It identifies services and gaps, and then it seeks to improve access and quality of services and supports. So currently, Youth Move National We have 67 chapters in 33 states, the District of Columbia, and 4 tribal territories. And so we have roughly just over 59,000 young people connected to our chapter membership at the local grantee and community level. And so we utilize our national platform to really unite those voices and causes of young people and then shape that into national policy initiatives, create workforce opportunities for these young adults. And each one of our chapter follows a kind of chapter purpose area. If you could go to the next slide. So our chapter purpose area, if you see here, youth-driven organization purpose area, this is kind of in the center of it is each one of our chapters agrees to the value of being youth-driven, that youth are able to sit at the table and create change and utilize their personal lived experience for advocacy within the system to shape a better system for those who are engaging. And so across this, we have several chapter purpose areas that many of our chapters select one and or more than one, depending the size and the scope of their local programming. And they really look at how do they create opportunities locally for their young adults. So you see in the top, we have peer recreation and peer networking. This is really informal peer-to-peer support. It's low barrier programming. Oftentimes we see this in a youth drop-in center type model where young people are able to, play pool, connect with other young people that are in similar situations to them, but also at the same time have safe space where there's also skilled and trained staff that would be able to help them with whatever issues might come up, whether that be service navigation or referral. But it's just a really great low barrier program for that 14 to 25-year-old young adult population that often isn't hanging out after school. Community involvement and advocacy is another strong component of many of our programs. Our chapters are getting directly involved within community activities. So, young people live in these communities. There's a lot of violence in our communities, and young people are really calling out what are the causes and issues for them in their community and how do they bring awareness around that and advocate for that. You would have seen that a lot with the gun violence that is out. One of our chapters in Florida was actively a part of really cultivating and being supportive to the school shootings, and we see this as well in several of our other communities, that those issues come up and young people jump in the center to kind of be a part of creating solutions and challenging the traditional system to shift and change. We also see this as an opportunity for many of our communities are also creating community gardens. And the community gardens are a project where our young people see that there is a need. They are creating and doing the gardening, and then they are donating the food back to local food shelters and the homeless. And so each one of our programs creates a project that works for them. And the next would be social marketing and awareness building. Often with mental health challenges and systems involvement, there's a lot of stigma that comes with that. So youth and young adults are creating social marketing campaigns and anti-stigma campaigns to bring awareness. We often see a lot of the older youth really going back into the school programs and doing anti-bullying and other types of to bring awareness around mental health, suicide prevention, and other issues that come up for them. Youth voice in the development and the leadership of training. So in order to be able to advocate and contribute back to the system's change, our youth leaders need to develop their own personal skill. And we do this through youth leadership development training, and we do this through skill development. So they're learning how to use their personal stories for self-advocacy. They're learning more about their own skill and what's needed for their own health, so they can be active contributors within their treatment planning. But then they're also able to be good role models for their community and for their other peers. And then the personal development and empowerment. This really is kind of like, I'm a recipient of service. I'm just getting connected to a community. What do I need to know? And how can Youth Move members and Youth Move National support me? And this really is kind of understanding your mental health journey. What does that look like for you? What do you need? How might you participate? what does outreach look like for a population that is often excluded, hard to reach, disengaged? How do we re-engage them? And so we provide a lot of supports and opportunities and curriculums to help the individuals stay connected. And then our last, which has been one of our most important kind of pieces of the growth of our movement, is peer services. And our peer services is a peer-to-peer support service that oftentimes can be informal and or billable through a Medicaid billable. And oftentimes this is where youth leaders have been a part of their own personal mental health journey and have been able to utilize their personal story to support others in navigating their journey of wellness. And so these peer-to-peer supports have been an enhancement to the formal treatment service and or offered in an informal way. These services, like I mentioned, can sometimes be billable through Medicaid, and other times they're informal, and that just depends on how the different states and service systems kind of integrate them within. But they've been very beneficial for young adults who are disconnected, disengaged. It's easier for them to seek help and reach out to someone closer in age to them, and then that person is being trained and supported on how to help them re-engage into the services and supports that they might need. So that is a little bit about us at Youth Move National, and a little bit about how our chapter purpose area really support the work of youth and young adults. This is, like I said, completely young adult driven. So this is really created for youth, by youth, and implemented by youth at the local level. And all of the youth engaged in our programming are all youth that have had some sort of systems involvement. And so it's a really great opportunity to convene them and to hold that space so that we listen to them and create solutions that really work for them. And looking at the time, I think I will hand it over for some questions and answers.
Thank you so much, Bree, and thank you, Joan, and thank you to Nia and Ruth. My name is Isha Weerasinghe, and I'm a Senior Policy Analyst at CLASP. I'm going to be facilitating the Q&A session. So just as a reminder, if any of you have any questions, please feel free to input those questions in that chat box, and we'll get to them as they come in. The first question that we received is for Joan. Joan, you were talking a lot about the screening process at Mary Center. Do you have any data in your surveys on how effective the screening process has been? And is there an accessible list of the different methods of screenings performed for postpartum women? And the person who asked the question was also asking whether that list varies based on the provider.
So in terms of data regarding the effectiveness of the screening, that's a tough one because we screen, and if we use tools that have been validated across the populations that we're serving, and it's also what's been recommended because we're part of a systems change, and it was recommended by a committee that was looking at validated screens and what could we recommend for the city to use. So that's why currently we use the Edinburgh for perinatal depression screening. Mary Center also uses the PHQ overall. In terms of the effectiveness, it's hard to know. I mean, we do identify through that process, but it's hard to know if someone hasn't been identified, if later on they may come up with a perinatal mood or anxiety disorder in some other location. It's hard to track that data. That said, in addition to screening, folks are trained in terms of talking to the participant, reviewing the questions with them, gathering a little bit more information about what's going well. Are there challenges? How has it been since you gave birth? What's it like being a parent? Are you sleeping? Those kinds of other additional questions are asked by our providers, and as part of the champions training that we provide to the folks that then train others to do this within their centers in terms of how you really talk to a participant in a way to gather information non-judgmentally in addition to the screening. And what was there another question?
I think you answered the last question. Just as to whether the screenings vary based on the provider, but I think you touched on that.
Well, right, and regarding the screenings varies based upon provider. There are recommended based. You want one that's been validated. The thing is, the providers need to be trained, and whoever's going to do it, how to talk to the participant about them and have that participant answer those questions and have the discussion. Yeah.
Thank you, Joan. I have a question for Bree. So you spoke a lot about the great model that you have at Youth Move National and how it's multifaceted. How do you promote your model to areas in which they may not have utilized a youth-driven model? And for those communities that are interested, how do they get in touch with you?
So Youth Move National, if you are interested in if there's a local chapter within your community, our website, youthmovenational.org, has a map, so you'd be able to find out who is the youth leader that is driving the local community work in your community that you could reach out to. If there is not a local chapter and you have a desire within an organization to start a chapter, we have a really great kind of chapter readiness checklist. What does it mean to be a chapter? What does it look like to get started? That will walk you through the preparation phase. And then what we do is there's a short application that youth leaders from your community could complete that kind of helps create who they are as a unit, identify kind of what's helping and what's harming within the local community that they want to drive for community change. And then you could start your own local chapter. If you are an organization or a system that is looking to become more youth guided, perhaps not having its own chapter in it, we also offer a lot of training and technical assistance on exactly how do you do that? How do you become youth guided and youth driven within your service system? And that means everything from sitting and advising at policy tables to direct intervention and services. We have a lot of organizational self-assessments that we created that will allow you to measure kind of where you are and where you want to go with your youth engagement and outreach. And you'd be more than happy to reach out. My contact information was on the very first slide. You could reach out to us and we'd be able to create something tailored for you or help you decide if creating a chapter is really benefit to your agency or community.
Thanks, Bree. That's very helpful. We also have a follow-up question to that. Do you have data on how the Youth Move chapter in DC has impacted youth specifically in Washington, DC?
So for Washington, D.C., we are just running and analyzing numbers now. What we collect is more chapter and organizational data. So individual membership data, like what are the benefits as an individual participant within the program. We are just launching out a new membership survey that will get at individual level outcomes this summer. And so we will have individual outcome data specifically for our DC chapter once that is completed. Right now, what we have is we have data related to the types of activities, what each chapter program offers, and what that looks like specifically for your community. So if you reached out, I'd be more than happy to pull up their report and share a little bit more about the services and supports that they're currently offering and what their impact numbers have been. I just don't have their specific report in front of me to share with you, but I can if you reach out.
Thank you, Bree. Next question is for Ruth. What can people do to help make sure Medicaid is strengthened and improved for moms?
So the first thing that people can do is that it's really important to speak up for mothers of color, provide historically and culturally relevant and linguistically appropriate care and services, and just be sure that funding is created to serve all mothers. And also, you can also connect with your legislators if they need to hear about how Medicaid benefits people in your communities. They want to hear your voice. It's also important to advocate for Medicaid in expansive state if the state hasn't yet expanded. So it's important to advocate for them and explain the benefits to mothers of all backgrounds.
Thank you, Ruth. And then next question's for Nia. Can you give an example of where you've seen innovations in state-level policy to address the mental health of youth and young adults?
Sure. So one of the things that we're working on as part of the project that I mentioned at the very beginning is a scan of 4 states and 3 localities that are doing some innovative things in the young adult mental health space. And we are anticipating having some products out this summer that will share in some detail some of what we found and some of what we've been learning. But some of the exciting things that we've learned about so far related to what Bree was talking about in Oregon. There's really a network of youth drop-in centers that covers a lot of the state. And while, those sometimes in some places there's one or two of those centers, there really is sort of a solid statewide network there that has the type of space where young people might come in saying they need a job or because they're homeless or, whatever. But then once they're engaged, often by youth care specialists in these places, they can move on to meeting other needs, including their mental health needs. So that's been one thing that's been really cool. New Mexico, there's a lot of really great work at the state level around youth engagement and really sort of at the state level, looking at ways to incorporate youth voice, youth leadership, youth perspective across all of these different kinds of systems. And while, a lot of localities do a good job with that, it's less common to see that type of work done effectively at the state level. So that's been pretty cool. And then we've also been talking to folks in Louisville, Kentucky. There is a tough state context there. But at the local level, there's been some really exciting work in terms of root cause analysis and thinking about not just sort of outcomes, which they think of as the leaves on the trees, but what are the roots, what are the pieces that are behind that, what's in the soil, what's in the air, sort of the whole context and how that shapes outcomes, both for young people and for residents of Louisville more broadly. So those are some of the cool things that we've been hearing about that we're thinking about featuring and looking forward to sharing more.
Awesome. Thank you, Nia. So with that, we're out of time. So if any of you have any additional questions that come up, please feel free to reach out to any of our presenters today. And I want to thank all four of you for taking the time to present on your work. And for those of you participating, we included a webinar survey. Please fill that out as you exit the program. We really would appreciate your responses and crafting our future webinars. Thanks so much.